Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today we're going to discuss about corneal graft rejection, its possible causes, pathophysiology, its clinical features, and possible treatment. When we talk about cornea, it is a special structure in the eye. It is avascular, and due to its avascularity and no blood supply, it is transparent. And also due to no blood supply, when we go for corneal transplantation, we take out the sick cornea and put the new cornea of graft over there, so there are less chances of graft rejection. Graft rejection is basically an immunological reaction against a donor. Yes, graft rejection is immunological term which is used to define the rejection of body against any foreign thing which is applied over there in the body against any donor. So as I mentioned, it is avascular, no blood supply. It has also got no lymphatic supply over there. So all this avascularity maintains the clarity in the cornea. And when we remove the sick cornea and put a healthy cornea over there from a donor, so its chances of survival are very high. It can, for example, if we talk about the normal keratoplasty, corneal transplantation, its survival can go up to 95% in 5 years. Plus and included if the proper immunosuppression treatment is carried out, which is usually in the form of topical steroid eye drops. Well, apart from this, they have been developed different techniques to replace the different layers of the cornea. When we talk about deep anterior lamellar keratoplasty, it means we have taken the superior chunk of the cornea, the interior cross-section of the cornea. This way the posterior part of the original of the recipient remains over there, and we only put the superior portion, the anterior portion of the donor. So the chances of graft rejection from the whole cornea are no more there. So its chances are quite high because the posterior part is of the original patient and the anterior is from the donor. So that is the deep anterior lamellar keratoplasty. But today we are basically talking about a case in which we will see about penetrating keratoplasty and the graft rejection signs and symptoms. Talk about the clinical features. Usually when a corneal transplant has been done, graft has been placed over there, and if the things are not going fine and the patient is going to develop graft rejection, the first thing we usually see is that blood vessels from the limbus side, they start encroaching in the cornea. Then along with it there are stromal infiltrates which are possible to appear over there, and then there is a demarcation line develops between the healthy and the sick cornea. That is called for the Dost line, which basically differentiates normal and the abnormal cornea, and it develops at the level of endothelium, the sick and the normal junction. At that it develops. Then the cornea which is going to develop rejection, of course the endothelium is damaged over there and it develops corneal edema. So basically we see these things: neovascularization, new blood vessels growth, corneal edema, stromal infiltrates. Sometimes we see capes, keratic precipitates over there. So all these things contribute towards the clinical features of the graft rejection. Yes. When we talk about the risk factors, there are multiple risk factors. They may be donor related, they may be surgical technique related, they may be patient related, who is receiving all these things. So the most important thing, if we talk about if the surgery is done and the corneal transplant has been done and there were already new vessels over there, vascularized area was, and that thing was not addressed and treated earlier, the chances of rejection are quite high. Then in young patients, the rejection can happen because of the immune response against foreign bodies which have been applied over there. Then also very important, the patients who have got corneal burns, dry eye patients, in which the normal anatomy has already been disturbed. In those patients, the chances of rejection are quite high. Also, those patients who have earlier history of graft rejection. Then we can talk about the donor cornea. If the donor cornea is not very healthy, the endothelial cell count is already very low, or during surgical meticulous care has not been done, precautions have not been addressed and not properly handled, the technique is not very good. Larger corneas over there, grafts is large size button has been taken. So these things can also contribute to the graft rejection. When we talk about the different layers and their response in graft rejection, endothelial layer plays the most significant part in the rejection. Yes, epithelial and subepithelial part of rejection is also important, but the most significant is the endothelial layers. Where all this is happening, the endothelial cells are getting damaged, that line is developing over there between normal and abnormal, sick and healthy cornea, and edema is happening over there, and new vessels are encroaching from the limbus. So mostly it is the endothelial layer which is the causing factor. Well, when we talk about the treatment and the management, the timing is very important. The earlier the situation is picked up, the patient comes, the results are better, and the most important thing is to go with the topical steroids. Steroids are prednisolone acetate eye drops, should be given aggressively to these patients to control this immunological reaction which is going on over there, and once the situation comes control, these drops can be decreased. Along with this, cyclosporine eye drops are very beneficial, and nowadays tacrolimus also we are using to control these cases. Yes. Apart from this, in literature, if we study, many people have tried the use of intrastromal and subconjunctival bevacizumab to control the growth of new vessels over there. But practically, we are basically using topical steroids along with cyclosporine and tacrolimus eye drops in resistant cases which are not getting controlled. Now please have a look at these photographs of a patient who has undergone penetrating keratoplasty, corneal transplant, and then he developed graft rejection. Here you can see that new blood vessels are growing and encroaching the graft from 360 degrees. You can see these blood vessels nasally, temporally, superiorly, and there are also corneal haze. This haze develops when the endothelium cells are getting compromised, their pumping action has been compromised, edema develops, and then all these things are happening over there. So you can see there was no more stain. We tried to do the staining. No, it was not picking up the stain, no CED. But basically you can see the patient superior part which is encroaching even the visual aqueous. You can see that the pupil has also been to some extent involved. So this patient was put on aggressive treatment of topical steroids, and it was controlled. Another photograph, here you can see how much it is aggressive now, the vascularization, large feeder vessels, new vessels. The feeder vessels, corneal new vessels, there the characteristic feature is when they develop, They come there. There is an afferent vessel. They make loops to the cornea. Then there is efferent loops over there in afferent blood vessels. So they develop this circle eye, and they are really difficult to handle. And here you can see what has happened because of the graft rejection, that the cornea, which was initially involving the superior part of the pupil, the visual axis, now it is more than that. You can say 95% it has encroached the pupillary area. So this is another photograph. It shows you when we go for aggressive treatment, tacrolimus eye drops, cyclosporine, one of these can be used along with the aggressive topical steroids. Then the things can come under control. We can reverse and control this immunological reaction. So here you can see to some extent, particularly in which there is a slit has been created, you can very well see a demarcation line, a zone which is between healthy, transparent and opaque cornea, you can see. But it is to some extent under control in this patient by the use of immunosuppressive therapy. Some other photographs, here you can see that the inflammation which was at the limbus, the red inflamed blood vessels, they have, because these blood vessels have got lymphocytes, they have got anything which can cause the over there graft donor recipient reaction. Yes, these have got T cells, they have lymphocytes, they have plasma cells, everything is over there. So here you can see because of the good treatment, that zone, that pupillary zone now is clearing up to some extent. As compared to the last photographs, here you can see to some extent it is decreasing. Well, when we talk about the new vessels, I have earlier discussed in my presentations that corneal neovascularization, there are different treatment modalities which can be done. Some people go for electrocautery over there to control it. Whatever treatment can be done. But these are the basic cause which is contributing it. But talking particularly about this patient, here you can see that things are improving in these slides. Not very crystal clear, but things are better. The latest photograph, here you can see that things have improved to great extent, at least if we talk about the visual axis, partial, I am talking partial, but it is there. So doing the corneal transplant surgery is one thing, and then managing this complication is another thing. And all these things should be anticipated by the physician before going for the surgery, which I mentioned over there, that the age of the patient, graft condition, and eye condition, any burns, chemical injuries, and size of the graft, all these things matter a lot in the surgery. And when we talk about graft rejection, it is purely an immunological reaction. Yes, but when we talk about graft failure, that is a broad term in which so many things come. Infection can come in over there. So it is a broad term which covers and all these things. But rejection is particularly an immunological reaction. So this was a very interesting thing which I wanted to discuss with my respected audience, that how corneal transplantation can be challenging in some cases. That's why people are moving towards deep anterior lamellar keratoplasty. By deep anterior, we take the anterior portion, so less part of the donor is over there. Anterior part of the cornea of the donor is being used, deep anterior lamellar. When we talk about DZAC, we are only using the posterior part of the donor's cornea over there. So these things, basically the purpose is that minimize the interaction between and the minimal donor portion should be taken over there. Yes. So I hope my today's presentation will be beneficial to my respected audience in their clinical practice when dealing with corneal grafts patient, its management, and when we are giving with this topical steroids, also we have to keep an eye on the intraocular pressure. It can rise sometimes. Some people are steroids responders. So this thing is also very important. So I hope this presentation will be beneficial to my respected audience. I want to thank you for your attendance and attention. Thank you.